Good afternoon, everybody. My topic is about the endocrine disorders screened on the newborn screening. These are your congenital hypothyroidism and congenital adrenal hyperplasia. For congenital hypothyroidism, what is the thyroid gland? The thyroid gland is a butterfly-shaped organ located in the base of your neck. The thyroid gland uses iodine to make two main hormones, your triiodothyronine or your T3 and your thyroxine or your T4. Thyroid hormones are essential for brain development and growth. They also regulate the body's metabolism. How is the thyroid hormone regulated? So this is your hypothalamic pituitary thyroid axis. The pituitary gland and hypothalamus both control the thyroid. Hypothalamus produces your TRH, which will stimulate the pituitary gland to produce your TSH gland. And TSH then will stimulate your thyroid gland to produce the T3 and T4. When the thyroid hormone levels are low, the hypothalamus secretes TSH releasing hormone or your TRH, which will alert your anterior pituitary to produce your TSH. The thyroid responds to this chain of events by producing more hormones. If the thyroid hormones are normal level, they will send a negative feedback to your anterior pituitary and to your hypothalamus to downregulate their production so that there will be normal regulation. Congenital hypothyroidism is inadequate thyroid hormone production in newborn infants, and the following are the causes. The most common cause is due to an abnormality of the thyroid. These are your thyroid dysgenesis, which are small thyroid or hypoplasia, hemiplasia. It's either the left or the right thyroid is the one present, or agenesis, wherein there is absence of thyroid. Another form of dysgenesis also is your ectopic thyroid gland. Next cause is due to your thyroid dysharmonogenesis, wherein there is a defect in your thyroid hormone synthesis because of enzyme deficiency. Number 3 is the most common cause of transient congenital hypothyroidism. The transplacental passage of maternal medications such as your antithyroid drugs, medications high in iodine such as amiodarone. The presence of maternal blocking antibodies which are passed into the neonate. This blocks the TRH of the fetal thyroid gland. Other is the presence of iodine deficiency or excess. Lastly, pituitary and hypothalamic abnormality causes your secondary and tertiary hypothyroidism respectively. Congenital hypothyroidism is one of the most common preventable causes of mental retardation in children. It can be detected through newborn screening, and early treatment can prevent neurocognitive delays. CH affects an estimated 1 in 2,000 to 4,000 newborns. In the Philippines, as of December 2019, the prevalence of CH is 1 in 2,716. Most cases of CH are sporadic, but when inherited, the condition usually has an autosomal recessive pattern. Most neonates born with CH have normal appearance and no detectable physical signs. If not diagnosed or if treatment is not commenced immediately, the following findings are seen. So these are the early findings of congenital hypothyroidism: the presence of macrosomia, decreased activity, large anterior fontanelle, edema of the eyelids, hands, and feet, the presence of prolonged jaundice, hypotonia, coarse facial features, hypothermia, pallor, goiter, and protuberant abdomen. While these are the late findings seen in untreated congenital hypothyroidism after the neonatal period: poor sucking effort, developmental delay, decreased activity and lethargy, presence of poor growth, umbilical hernia, mottled, cool, and dry skin. There will be difficulty of breathing, probably due to your macroglossia, presence of generalized swelling or mixed edema, and hoarse cry. Okay. Because of the implementation of the newborn screening program, we are able to detect and diagnose newborns with congenital hypothyroidism. The newborn screening screens for TSH only, and it uses the TSH4 screening. This method may miss hypothalamic pituitary hypothyroidism and hypothyroxemia with the TSH elevation. So when do we consider this newborn screening to be positive for CH? Here are the cutoff values. TSH of more than 15 for term babies and more than 12 for preterm babies. So if we receive a newborn screening with these results, the newborn screening facility will be recalled by the newborn screening center to recall the patient. So we will do a confirmatory testing and an urgent referral to a pediatric endocrinology. So what confirmatory tests are requested? Your serum TSH and your free T4. How do we interpret the confirmatory test? An elevated TSH and a low levels of FT4 confirm the diagnosis of congenital hypothyroidism. So upon diagnosis, treatment should be commenced immediately. The golden period to start treatment is 2 weeks of life. Other tests to request for congenital hypothyroidism.
Proper treatment and monitoring is very important to ensure normal growth and neurocognitive development. Initially, we start the patient on levothyroxine at 10 to 15 microgram per kilogram per day. And the frequency of thyroid function monitoring is as follows. After 2 to 4 weeks after starting treatment, then every 1 to 2 months for first 6 months after birth, and then every 2 to 3 months between 6 months and 3 years after birth. Then, if we see that the congenital hypothyroidism is a permanent condition, we do it the monitoring shall be done 6 to 12 months after 3 years old. Our target TSH is less than 5, ideally between 0.5 to 2 milli-international units per liter. And our target free T4 it should be on the upper half of laboratory reference range. No, ayaw mag-proceed. Okay, continue. These are the recommended levothyroxine treatment doses. These are the age range, and these are the levothyroxine doses. For 0 to 3 months, we give levothyroxine at 10 to 15 microgram per kilogram per day. 3 to 6 months at 8 to 10, 6 to 12 months, 6 to 8, and as follows. For adults, we give 1.6 microgram per kilogram per day. So how do we assess the permanence of congenital hypothyroidism? If the initial thyroid scan shows ectopic or absent gland, the CH is a permanent condition. So it needs a lifelong treatment. However, if there is a normal thyroid gland on ultrasound or in the scan, and there is no increase of TSH after initiation of treatment and monitoring, we do trial of therapy at 3 years of age. Trial of therapy is we discontinue the levothyroxine for 30 days, and then we get serum TSH and FT4 after. So how will we interpret the result? If the free T4 is low and TSH is elevated after trial of therapy, the hypothyroidism is a permanent condition and levothyroxine should be reinstituted. But if the free T4 and TSH remain in the reference range, euthyroidism is assumed and a transient hypothyroidism is likely. However, monitoring should be continued and child should not be lost to follow-up. I got this post from the GMA Public Affairs just this October. This is a 28-year-old female from Sorsogon diagnosed with CH na untreated. Her capability is that of a 9-month-old. Okay, newborn screening is not yet that, wala pa noon. Okay. The next topic is congenital adrenal hyperplasia. This is a group of rare inherited disorders of adrenal steroidogenesis. CAH arises from a deficiency in enzymes essential to the production of cortisol, which is your stress hormone, and it's responsible for glucose homeostasis. Aldosterone for salt and water retention and potassium excretion. Androgens, the male sex hormone. All forms of CAH are inherited in an autosomal recessive pattern. Here, both the parents are carriers of the defective gene. What are the causes of your CAH? The most common is your 21 hydroxylase deficiency, followed by the 11 beta hydroxylase deficiency, and the rest. Okay, this is the adrenal steroidogenesis pathway for cortisol, aldosterone, and steroid synthesis. Cholesterol is the precursor of all steroids of both gonadal and adrenal origin. The conversion of cholesterol to the various hormones requires the sequential action of series of enzymes. Okay, we will discuss the most common, which is your 21 hydroxylase deficiency. In 21 hydroxylase deficiency, the pathway to your aldosterone and to your cortisol is blocked. Hence, there is low levels of aldosterone and cortisol. With the low levels of aldosterone and cortisol, the patient will have hyponatremia and hyperkalemia. Low levels of cortisol, hypoglycemia is present. Above the blocked pathway, the precursors will increase. So, if you see this, precursors will increase, they will go to the unblocked pathway, which is the sex steroid pathway. So there will be increase in your DHEAS and your testosterone. Increased sex steroids will cause the virilization in female newborns. CAH due to 21 hydroxylase deficiency has two categories: your classical CAH, which is the severe form, and again subcategorized into salt wasting, which is the most fatal if not treated, and your simple virilizing form. Another category is the non-classical CAH, which is a mild and a more common form of CAH due to 21 hydroxylase. The prevalence of CAH in the United States and Europe, it is 1 to 10,000 to 1 to 15,000 cases. While in the Philippines, as of December 2019, we have 1 in 20,027 cases. So what are the clinical manifestations of this 21 hydroxylase deficiency? Female babies with severe virilizing CAH have ambiguous genitalia. It's either they have clitoromegaly, variable labioscrotal fusion, but no gonads palpated, separate urethra and vaginal orifice, or a common urogenital sinus. You see in this picture, on first, unang tingin pa lang, you will note that this is a male neonate. However, if you will palpate the scrotal folds, no gonads are palpated. And if you put this up, the phallic structure, if you put it up, you might see two openings, that of the vagina and that of the urethra. Urethra will present as a hypospadia for most of the cases. Affected males have normal genitalia. For non-classical CAH, they present later in childhood because of precocious pubic hair. There is a phallic enlargement in males and clitoromegaly for females. There will also be accelerated linear growth. For patients who goes into adrenal insufficiency or crisis, there will be hyperpigmentation of the skin and the genital area. There will also be poor suck, failure to thrive, dehydration, seizures, shock, and coma. Again, because of the newborn screening, we are able to detect this condition early and treatment is commenced early. So when do we consider the newborn screening positive for CAH? Here are your cutoff values. For term babies, 17 OHP of more than 40, while preterm of more than 50. So when we again when we are recalled by the newborn screening center to recall the patients, what do? We do confirmatory testing and urgent referral to pediatric endocrinology. For the confirmation, we request for your serum 17-hydroxyprogesterone plus your serum sodium, potassium, and your random blood sugar. Okay. To confirm CAH due to 21 hydroxylase deficiency, the following are the results. There will be elevation of your serum 17-OHP in addition to hyponatremia, hyperkalemia, and hypoglycemia. If the patient is in crisis, metabolic acidosis are seen. So when you receive the confirmatory test, urgent referral is needed. In neonates with ambiguous genitalia, always consider the salt wasting type of CAH. While awaiting for the newborn screening result, we can do an abdominal ultrasound. This is to detect the internal anatomy. Baka meron namang uterus doon, kahit phallic structure, but it has uterus. Most probably, XX itong baby natin. With ambiguous genitalia, karyotyping is also recommended. This is to establish the sex because of psychological and legal implication of wrong gender assignment. So for the other healthcare providers in other hospitals or newborn screening centers, facilities, let us not register the birth certificate immediately. You have to advise the parents not to register the birth certificate. Do not assign a gender in the presence of ambiguous genitalia. Let us wait for the karyotyping result. So treatment for CAH due to 21 hydroxylase deficiency, CAH cannot be cured, but it can be effectively treated. Treatment starts soon after birth and is needed throughout the patient's life. The primary goal of treating classical CAH is to reduce the excess androgen production and to replace the deficient hormones. So the medications, we have 3 medications usually given for 21 hydroxylase deficiency. Your glucocorticoids, this is to replace the cortisol. So what we give is the hydrocortisone tablets. Mineralocorticoids to replace the aldosterone, your fludrocortisone tablets, and we also give salt supplements or the sodium chloride tablets. So what are the side effects of this medication? These are all usually iatrogenic, Cushing syndrome due to high doses of glucocorticoids, elevated blood pressure due to high doses of mineralocorticoids and salts given, and growth suppression, especially with the use of long-acting corticosteroids, your prednisone and dexamethasone. We usually give these long-acting corticosteroids after completion of growth. So yung mga adolescent, pwede na sila once they reach their growth potential. Salt wasting CAH and crisis, usually they present with difficulty of breathing, vomiting, poor feeding, dehydration, and generalized hyperpigmentation. So what do we do if they are at the emergency room? We correct the shock and the dehydration, and then we maintain IV fluids after. We correct the hypoglycemia, hyponatremia, and hyperkalemia. And stress doses of hydrocortisone should be given immediately. Stress doses of glucocorticoids should be given during febrile illness and during gastroenteritis with dehydration, in times of surgery accompanied by general anesthesia, and when there is major trauma. This is to avoid adrenal crisis. Stress doses is also explained to the parents because they can give this if their child is sick. Stress dosing is we double or triple the maintenance steroid dose. So once the baby recovers, we can go back to the usual maintenance dose of steroid. Clitoral and perineal reconstruction should be considered in infancy for severely virilized females. For virilized female CAH patients diagnosed after infancy, patients and families' gender preferences must be considered. Okay. Monitoring hormone levels in individuals with CAH is crucial throughout their postnatal life. Height and weight are important aspects that need to be monitored in order to know if treatment should be adjusted, particularly in children. With proper treatment and monitoring, people with classical CAH can have normal, fulfilling lives. So in summary, CH and CAH are the 2 endocrine disorders screened by the newborn screening. Newborn screening makes early diagnosis and early treatment possible. This prevents adrenal crisis, which may lead to death in cases of salt wasting CAH. while neurocognitive delays are also prevented in patients with CH. Again, let us continue to promote our newborn screening. Thank you for listening. We have the newborn screening clinic here in the Cordillera. It is located in the outpatient department of DGHMC every Tuesdays 9 to 11. But since we are in pandemic, appointment is needed. While for Pangasinan Ilocos region, it is located at the outpatient department of ITRMC also every Tuesdays. Appointment is also needed. Thank you for listening.